Please say hello to Barbara, okay? And your
Of
kids.
course, I sure will.
Nicole arrived 1 week ago from Spain. We are so happy.
Oh, great. How long will she be home now?
She will spend 1 month here.
Oh, great. Well, give her a big hug for me.
Okay, thank Please you. Say hello to Barbara, okay? And your kids.
Of course, I sure will.
Absolutely. Nicole arrived 1 week ago from Spain. We are so happy. He's the
Oh,
you,
great. How long will she be home now?
she will spend 1 month here. YouTube is repeating our conversation. Okay, so okay, we are on time. Thank you very much. I will give my welcome to Professor Si Yang Wu, Professor of Surgery, Urology, and Pediatrics from the Warren Alper School of Medicine in Brown University. And he was, this is his second time collaborating with our program. And me, all friend and Dr. Professor Anthony Caldamone, Professor of Surgery and Pediatrics, the Warren Alper School of Medicine and at Brown University. Thank you for very much to be with us. Please welcome. See,
Thank you.
you are on command. Thank you.
Yeah, thanks again for asking me to inviting me to talk. Today I'm going to be talking about basic science in hydronephrosis and posterior urethral valves. I'm not going to go too deep into the basic science, but I am mainly going to focus on how this is getting translated into clinical use. This is something that I've been thinking about ever since residency. I was sitting in the lab at UCSF thinking, wow, wouldn't it be great if there was a test we could do on a baby with hydronephrosis that would tell us for sure this child needs a pyeloplasty, and we wouldn't have to submit them through recurrent diuretic renal scans or recurrent ultrasounds. And so I was working on tissue engineering at that point, so I never really did research on the biomarkers for hydronephrosis, but it's something that people have been studying for a very long time. So when I was a fellow in Philadelphia, Stefan Josephson, who did a lot of the initial classic studies in animals on hydronephrosis in the 1980s, came by to visit Steve Zedrick. And so I had a chance to sit down and talk to him. This was about 2000. And what Stefan felt was very important in doing basic science in hydronephrosis was to do a partial ureteral obstruction, because that actually mimics what happens in children and humans. There are a lot of papers that are done where you completely ligate the ureter in a fetal or newborn rat, mouse, or rabbit. And he felt that that was just not a good model. It's too severe. And I don't know if this was just his translation of the Swedish, but he called those studies an abomination. Basically, should not be done. He was like, you have to do a partial ureteral obstruction if you want to find out anything about markers and what the time course of resolution of hydronephrosis in humans should be. That's sort of a little bit introduction of sort of where my thinking on this has been. But let's talk about where we are now. Okay. So this term biomarkers gets talked about quite a lot. They can be anything from blood tests, urine tests, they could be imaging. The NIH definition from 2016 is a bit vague. I think intentionally so. It just says it's a characteristic that's measured. Is it just normal biology, pathology, or is it a response to treatment? The way I look at it, a biomarker for hydronephrosis or posterior urethral valves is some kind of biological test that will predict what's going to happen to that kidney and the overall and relative renal function over time. That's a really useful biomarker. And we want something that's going to give us a prediction of what's going to happen, not just respond to surgery. So there are papers, experimental papers that are out there that say, oh, if you measure this level, this protein, et cetera, it goes down after a successful pyeloplasty. And to me, that's not really that helpful because I'm going to get an ultrasound on that child anyway. The other test is like, well, it's good, but it's not really helping me decide which child needs the pyeloplasty and which child can be observed. So the other thing that a good biomarker should do is it should give us more information. It should outperform what we currently have in terms of imaging, blood tests, and urine tests, okay? And so the other thing that I would tell you as you're reading papers, if you happen to come across a paper that says, oh, this is a good biomarker, the biomarker has to be better than just saying there's a difference between normal patients and patients with hydronephrosis, okay? Because we can tell that with the ultrasound. We already know that, okay? What the biomarker should do, it should tell us which patients with grade 3 and grade 4 hydronephrosis will eventually need surgery based on the first test that you get when they are newborns. Because a lot of these patients are now being diagnosed prenatally, obviously, and that's how they come to our attention. It's rare now that a patient will show up later on in life with symptomatic UPJ obstruction, but that still happens. There's some progression of mild hydronephrosis that can occur with time. Okay, so that's what I think a useful biomarker should be. So what do we have right now? So we have always relied on imaging. So with the ultrasound, you can look at the grade of the hydronephrosis, either the SFU or the UTD systems to look at that. You can look at the AP diameter. Is it 15, 30, 45 millimeters? I think this is a good one. Renal parenchymal thickness. How thick is the parenchyma? How thick is the renal pyramid? And if it's really compressed, is that a good enough marker for you to say this patient needs surgery? Now, it's also similar to the grade, right? Because if you have grade 3 or grade 4 hydronephrosis, the renal parenchymal thickness is going to be a little thinner. The problem with all of our grading systems is that depending on who's reading the ultrasound, whether the radiologist or the urologist, you're going to get maybe a slightly different grade. And that might throw off how you decide to follow a patient. And then finally, I think the gold standard we have still is the diuretic renal scan. And whether you weigh the relative function or the drainage of the kidney as the more important thing, it depends on how you're trained and what you believe is important. Now, we also have blood tests like the creatinine cystatin C. You have urine tests. You can do a 24-hour urine creatinine clearance, or you can look at the urinary protein spillage, specific gravity of the urine to assess the function of the kidneys. But the problem with all the serum and the urine tests is that you are looking at the function of both kidneys, not just the one hydronephrotic kidney. And if you do have two hydronephrotic kidneys, it becomes a much more challenging clinical scenario to decide what to do. You operate on the more hydronephrotic one, you do the better one. And so this is where we are. Okay, so for unilateral significant hydronephrosis, in 2006, there was a great paper that came out, and that made me think, aha, we have it, okay? We have a way to figure out which of these babies is going to need a pyeloplasty. This was done by Stéphane de Kramer in France, and what they did was they looked at the urinary protein for neonates with intermediate hydronephrosis, and basically they figured out a set of proteins that would tell you with 94% accuracy which patients would need surgery 9 months later. So this sounded wonderful. Okay, it's like, oh, we've finally gotten to the point where a biomarker can tell us what to do. But then, about 4 years later, a follow-up paper came out, and they tried to apply the same biomarker set to children who were over 1 year old. And it was totally inaccurate. It was about as good as flipping a coin. So what happened here? What we think happens is that the fetal and neonatal kidney, as it develops, continues to change its protein expression. So what's true for a neonate may not be true for a 1 year old or a 2 year old who comes in later with pain. So let me show you the initial data from the 2006 paper. Again, this is the one that had a 94% accuracy here, picked out 34 out of 36. Okay. And what they did here is like, oh, if you had a black mark, that was more likely to tell you that you were going to need surgery. If you had a white mark, you were probably not going to need surgery. And then white is did not need surgery, black is did need surgery. So you can see for most of them, there's a good matchup between what the biomarker set said and what eventually happened to them. But I do want to point out the two misses here, okay, are on patients who you think would need surgery. Here's one, okay, followed it down, did not need surgery, okay, and the higher the number is, the more likely is that you're going to need surgery. And here's one that's a big miss, okay, -1, didn't need surgery. Interesting, okay, and so let's look at the AUC curves, because this is, I think, an easier way for us to understand how accurate a test is. Okay, and this is from the follow-up paper that was done in 2010. Now, the graphs you see here is they looked at the initial paper, the neonates, under 1 year of age, and you see an area under the curve for the receiver operating characteristic curve of 88%. And that's not bad. And then you look at 1 year of age, area under the curve is 57%. That's very close to that 50% line, which is a flip of the coin. But the other thing that you need to think about is how accurate is this AUC curve? So if you look at the 95th percentile confidence interval in this graph, this is pretty good. That's very close to where the AUC is. But if you look at this confidence interval here, you can see that's really bad. I mean, you almost have the entire graph taken up by the 95th percentile confidence interval. So yes, the AUC is good, but how accurate it actually is, this suggests that there's actually a great deal of variability in the data here. And maybe it's just because they had a small number of patients that were there. When you look at the patients that are over 1 year of age, yeah, this is a pretty bad line, but then the confidence intervals are also very large. One of the things I always forget is, so how do you interpret an AUC? Okay, if an AUC is greater than 90 percentile, that is good performance. If it's over 80 percentile, 80%, then that's clinically useful, but you have to throw a lot of judgment in there. If you're between 80 and 50%, it really becomes hard to say that this is a good test, okay? So based on that, yes, the AUC here, almost 90%, that's probably a good performance test, but the confidence interval is extremely large. For this one, 57%, this test is not worthwhile doing, okay? And you also have very large confidence intervals. So when you're we're trying to interpret papers on this, you need to look at the AUC and also the confidence intervals to understand what is going on. So what is the major problem that we have in trying to diagnose significant UPJ obstruction in unilateral situations? The problem with all of these urine tests, blood tests that we do, is that we are not looking purely at obstruction, which is what we're interested in as urologists. The kidney responds to injury, whether it's a urinary tract infection, medical renal disease, glomerulonephritis, other things, with the same response. It's going to spill out more proteins that you're looking at. So that's one problem. We're not being really accurate in terms of looking at obstruction. The other thing that you face is that you have two kidneys. If you have a normal contralateral kidney, trying to figure out which of these markers is actually coming from the obstructed kidney becomes much harder. Yeah, and ideally, you could stick a needle into the renal pelvis and get renal pelvis urine in the hydronephrotic site, and that would probably give you, the most accurate assessment. But most parents aren't happy to let you do that. If you're going to do that, you have to decide, is it worth putting the child to sleep and just doing a pyeloplasty on them? So if you want to get away from the urine problem, you could say, well, let's look at the blood. Maybe there's a biomarker, something we can assay in the blood that's only secreted by the obstructed kidney. Unfortunately, we don't have that, okay? And I think even if we had that, it would be similar to the problems that we have with prostate cancer and the prostate-specific antigen, okay? You can have an elevated PSA from either prostate cancer or BPH. And so just getting the blood test doesn't tell you which of these conditions is going on. And we might see the same thing if we were going to get a serum biomarker for hydronephrosis. If you happen to have obstruction on one side, some kind of nephrological disease, say the child had a UTI or some kind of medical renal problem, that serum biomarker also may not tell you exactly what's going on and which patient needs surgery. Okay. Now, to save you time, I'm not going to go over the hundreds of papers that have looked at candidates for biomarkers. There are two very good recent analyses. There's a systematic review from 2020, which was done by Gariboli in London. I'll refer you to that one. There's a meta-analysis from Ramesh Babu in Chennai. And I'm going to show you some of the graphs from that. And so instead of having to look up hundreds of papers, just look at these two systematic reviews, okay? And they will give you some really good summary of all the proposed biomarkers. And, they do focus on about 6 of them. And the one that I have looked at the most and heard about the most is NGAL, okay? And again, if you look at the AUC numbers here, sometimes it's good and sometimes it's bad, okay? It's not consistently at 0.8 or 0.9. MCP1 similarly, 0.66, 0.93. CA 19.9. This is something that's still being studied fairly frequently, 0.73 to 0.89, and KIM1, 0.65 to 0.89. So why do we have these very different AUC numbers? The problem is that all of these studies are done in very small populations of patients. Every lab that does them has different cutoffs for what level they feel is a significant cutoff. So there's no standardization of these AUC numbers. So if you pick up a paper and you happen to do the assay a little differently than they do, it may not be accurate for you. Okay, so that's one of the problems, that not everybody's doing these assays the same way, and they are looking at different populations. Some are comparing controls with patients with hydronephrosis. Some are comparing grade 3 and grade 4 patients. Which I think would be a more accurate way to look at this. So let me show you a sample curve from the Sangeeta paper in 2022. Again, this is for NGAL, something that's been studied for a very long time. And again, for your sensitivity, not bad, almost 80%, specificity, almost 80%. But what I would point out to you is, again, look at the confidence intervals on all of these papers, okay? That's your 95th percentile confidence interval. It almost spans the entire range, okay? A lot of them have this huge interval here and here. So even though this looks good, the actual data points can be very, very far apart. So it makes it hard for you to know which cutoff to use. And for the specificity, it's a little tighter, but then you have some papers where, it's really out of range. So this becomes difficult. If you're going to interpret this, you need to know exactly what ages these patients are, what cutoff they use, what kind of technology they use. So it is still something I don't think we have a great answer for in terms of unilateral hydronephrosis. Hopefully somebody will come up with something down the line. But I think we're still always going to be faced with a problem of diagnosing what's going on in one kidney when there are 2 kidneys and trying to figure this out from the urinary biomarkers that we have. Okay. Let's go on then to posterior urethral valves, because that might be an easier situation for us to get accurate numbers on. And obviously, the difference in posterior urethral valves is you have obstruction of both kidneys. And so you don't have the issue of the biomarker being diluted out by the normal contralateral kidney. Now, what are we looking at? The posterior urethral valves. The reason that this would be an important thing to diagnose is you really want to know what the renal function of this fetus is going to be. You don't want to put a shunt in a patient with Prune-Belly syndrome or bilateral megaureters. If you have a patient with good lungs, but the kidneys look pretty bad, and the parents are not really thinking that they want their child to go on dialysis after birth and then eventually need a kidney transplant, that decision for termination of the fetus has to be made within a certain time frame in terms of when that's still easy to obtain in whatever country you're in. And so, what people have looked at is, again, fetal urinary proteomics. And what exactly are urinary proteomics in posterior urethral valves? So anything that you see with omics means you're sort of studying the entire range of the expression of whatever you're looking at. Proteomics is looking at the expression of proteins. And obviously in posterior urethral valves, we are looking at proteins in urine. The way that these studies are done is that you look at all of the proteins in the urine that might be of interest to you. And you start out with some animals. So you take some fetal animals, you ligate the urethra, recreating a posterior urethral valve situation. And then you compare the urine in these animals to control animals, and you pick out the ones that are significantly different over time. So it's a little different than what we used to do, where we would say, okay, I'm going to look at one possible protein. Here you're looking at all the possible proteins. You're not picking out one at the beginning, but you're looking to see what pops up, and then going with those proteins and combinations. Once you have some candidate proteins, then you look and see, does this hold true in humans? Humans are not the same as rats or mice or rabbits, and changes that happen there may not actually show up. And then you trim the number of proteins that you have down to a smaller number. So that's your initial set. And then you have to take another set of patients and validate that. Okay, so it's a lot of work progressing from animals to humans. You need a lot of analysis of proteins in order to do this, and it costs a lot of money. Okay, so how are these actually done? So this is covered in one of our papers with Juice Shanstra from last year. But basically, this is done with mass spectroscopy. Okay, I don't know what a current mass spec machine looks like. I only know from working with one in the late 1980s in the pharmaceutical industry. It was a huge tabletop machine, and I remember they were very happy that they had finally gotten an automated system where you could prepare, say, like 20 specimens, load it up, go home, and the machine would run it overnight, because it does take a little bit of time for these specimens to be shot through. Fortunately, sometimes when I came back the next morning, I wouldn't have any results. Sometimes the machine would get jammed. We put the wrong solvent in. So I think it's better now, but it still takes a bit of hardware, and you also need somebody who knows how to run the machine in order to do that. Okay. So once you have that, then you're left with several thousand proteins that are different. Okay, and then you have to analyze them. And so this is something that the geneticists are very good at, because they're used to looking at things like a genome-wide assay study, thousands upon thousands of things, and how do you decide which is significant, which is not? So here you need a technician who knows the mass spec. Here you need software to analyze these thousands of time points, and you need the input of the geneticist to say, okay, this is significant, this is not significant. And then finally, you need somebody like a urologist or a pediatric surgeon who's interested in this and say, okay, so these tests look this way. Is this actually clinically useful for us? And so this is a long development process in terms of trying to figure out something that would be helpful for parents who are the moms carrying a baby with possible posterior urethral valves. Now, getting back to that issue of what's different between babies, 1-year-olds, and adults, this is something that was pointed out by Juice Sandstrup. And what he pointed out with chronic kidney disease in adults and children is actually pretty different in terms of what happens in urine. And this makes sense because if you're a nephrologist, what you want to do is you want to develop a test that can be very clinically useful to a large population, and you're going to have a lot of adults with chronic kidney disease that you will make a diagnosis for. There's a market there, and the test might actually get some traction here. What happens in adults with chronic kidney disease is that they actually start having fibrosis of the glomeruli. And in that situation, you actually have less collagen being broken down. So in chronic kidney disease, when you have scarring, you actually have less collagen. And so they've developed tests in terms of looking at chronic kidney disease in adults, looking at which collagen proteins are underexpressed. Now, what happens in chronic kidney disease and early end-stage renal disease in children is that there's continuing change. I mean, the kidney is still trying to grow. It's trying to make up for the insult that it's received from the obstruction. And so because there's a lot of turnover, there's actually increased collagen breakdown. And so what they focused on here is which things are actually, which collagen fragments are increased in patients with posterior urethral valves and end-stage renal disease. So here's where we are. As of last year, the initial studies were done with a bladder tap. So that means you have to get the needle into the woman's uterus, you have to get the baby in the right position, and you have to stick the needle into the baby's bladder. Okay, it's similar to what you would have to do for a vesicoamniotic shunt in order to get the bladder urine out of the fetus. And what they just said was, okay, that's doable. Let's try something that's a little easier. Okay, why don't we just do a amniotic fluid assay? You don't have to get into the baby's bladder. You just have to put the needle into the uterus and get some amniotic fluid. And it's a little safer for the baby, but you have to do it at a certain time point to decrease the risk of clubfoot or injury to the baby. And so the most recent data that's been completed and from the study, the Bioman study in France in 2021, they looked at over 1,000 peptides. As you can see, a lot of numbers here. And as they analyzed all of them, they found that we're almost 100 of them that would differentiate end-stage renal disease from non-end-stage renal disease. Now, I want to point out this doesn't mean that the baby here is normal. They might have some chronic kidney disease, but then that has to weigh on the decision that the discussion you have with the parents. If you continue with the pregnancy, your child may need dialysis when they're older. They may need a kidney transplant. The lungs are okay now. However, if you look at the AUC for these 100 peptides, it's really good. It's almost 1, but 0.96, a lot better than the initial ones that we saw for the unilateral hydro. Decent sensitivity, really good specificity. Now, people said, great, we can get it from amniotic fluid. Currently, we're getting cell-free DNA from mothers, before the baby comes out, we can do genetic tonic. Can we just draw blood from mom and get an assay on what's being expressed here? And unfortunately, they did try that, but it's a little too far. You're probably not going to have enough of these proteins that you're finding in the amniotic fluid. It's probably not getting into the maternal serum to make that useful. So still somewhat invasive, less invasive than an actual bladder tap. But it's a pretty good test in deciding whether the baby will eventually have end-stage renal disease versus not so great kidneys. Okay, so where can you get this right now? You can only get it in the EU as part of a clinical trial. And the problem is that the mass spec equipment is in two central labs. And so if you think about, what's happening in the EU is that patients are getting enrolled in this trial, and they have to send the specimens, the amniotic fluid, to these labs, and then they run the labs. It costs about 1,200 euros to run 5,000 analytes, and it takes them about two weeks. So again, the issue here is you want to be able to get this in time to make the decision about termination versus continuing the pregnancy, and you have to do it 2 weeks beforehand, so you can offer the parents the information that they need. And I think the more disappointing thing, which is why I brought up the adult CKD studies, is that there's no interest in the pharmaceutical industry in developing this. Posterior urethral valves is a rare disease. Obviously, end-stage renal disease is very costly and management is difficult, but this is basically done as part of clinical trial that people are running right now. So while it's there, it's limited, and we're still at the point where it takes a long time and it's pricey, even though we've gotten to the point where the test itself is pretty good in telling us about end-stage renal disease. Okay, so to conclude, I think where we're going in the future is going to be a biomarker panel than a single test. The problem is I have a hard time interpreting 100 different proteins. I think we all do. And that's where we need somebody with expertise to tell us, okay, just give me a number. Okay, is this cutoff? This cutoff will tell us that the baby is going to have end-stage renal disease. And this says no. And so that way we can make a prediction about whether to put a shunt in, whether to terminate, or whether to continue with a pregnancy without doing any interventions. The problem with proteomics for unilateral UPJ is that it works okay for patients under a year, but because the kidney is still growing, you basically would have to come up with a different panel for patients over a year of age in order to do that. And because nobody's really done it past the year of age, we might run into problems, say, like maybe there's a 1-year panel, maybe there's a 2-year-old panel. Maybe the protein expression continues to change enough over time that we're going to have a hard time doing anything except the babies. Okay, and again, it may be accurate for kids under 1 year of age, good AUC, but a really wide confidence interval on that AUC curve. In terms of posterior urethral valves, thanks to all the good work that's been done in the EU on this is pretty accurate in figuring out which patient's going to develop end-stage renal disease, but we're still limited in terms of where you can get it, the cost, and the turnaround time. But it's an important decision for the parents, so I think this is fairly helpful for them. So that's where we are in 2025. In terms of the unilateral hydro, we're still having trouble coming up with a really good test. With posterior urethral valves, we have a test, but there are the typical issues that you run into because it's a rare disease, and it's not something that's going to be very easily obtainable through a commercial lab that you can just send the fetal urine, the sort of amniotic fluid out for. Great. Thank you very much. That's the conclusion of my talk, and we'll take some questions this time.
Thank you. Thank you, Si Yang.
Yeah.
May we hear before any question the commentary of Anthony, please,
Yes.
Anthony.
Sure. Young, I think that was a great presentation and certainly an area that I don't have a lot of familiarity with. I wasn't aware, for instance, of the difference of where we stand in terms of urinary proteins between a unilateral hydronephrosis situation and something like posterior urethral valves, but I can certainly understand that now. And clearly there are big differences. I would certainly echo your comment about needing this type of panel. I think that's very, very important because any of us who deal with the issues of prenatally diagnosed hydronephrosis. To a large extent, I mean, there's a certain population where there's no question where you're going with that, and another one at the other end of the spectrum as well. But that 50 to 70% in between, I think we all struggle with. And when do we do follow-up tests? When do we do ultrasounds? When do we repeat the diuretic renograms in order to get some indirect measure? And you always wonder if you're using those parameters, such as worsening of hydronephrosis, worsening of renal function, or delay in excretion, is the ready? How much of that is recoverable, and how much of that is just the way it's going to be for the rest of their life? And we're just trying to stabilize the situation and not necessarily improve on kidney function that they already have. So I think it's an extremely important area, but a difficult area. One question that I might raise with you, and this is a little bit off the path a bit. When we talk about posterior urethral valves, we talk, of course, about the long-term effect on kidney and what percent, that 30% that's going to end up in end-stage renal disease, almost no matter what you do. But is there anyone on the pulmonary side of it that's looking at urinary proteomic or proteomics in some way to measure pulmonary function in children? Because that's sort of the short-term red flag factor that we have to consider. And oftentimes, what makes one move towards a prenatal intervention rather than looking at renal function or the degree of hydronephrosis or the density of the renal parenchyma or the thickness of the renal parenchyma prenatally.
Yeah, I am not aware of anybody looking at that. I think I'll have to speak from my experience on the transplant service at Stanford in terms of dealing with these patients. And certainly what they would say is like, if these fetal lungs are not developed in terms of size, there's no way they can support that baby with both pulmonary failure and renal failure. It just is too much at this point to maintain. So I would, my assumption is that, if you think of it sort of like CDH, congenital diaphragmatic hernia, and, the pediatric surgeons sort of look at the, the ratio of the lung, the abdomen, everything else like that. Again, indirect measurement, like you're saying, okay, it's only looking at the volume of the pulmonary space, really.
Yeah.
I wonder if that's just, where that comes out. Now, it's an interesting point because like I said, it's an agnostic test in terms of what we're actually measuring. Okay. Obviously, the amniotic fluid is measuring what's going through the lungs. So we might be measuring, pulmonary proteins because we didn't pick out urinary specific ones, it's not even renal specific. So because of the way you're looking at every single protein that's coming out of the baby bladder, we might be actually, looking at some of these. We just don't know. But but yeah, I'm not sure how that exactly tells us more than sort of the lung size. And the same issue, these biomarkers, in order to be useful, they have to give us additional information compared to what we currently have. Something that just replicates what we have is not enough in terms of making a big change in how we manage patients. Yeah.
So are you saying that we cannot tell at this point in time, based on amniotic fluid sampling, the difference between pulmonary proteins versus renal proteins versus any other proteins that are processed?
I asked Juice, I said, okay, so how do you know if these proteins are coming from the kidney or the bladder? He said, I don't know. I don't know. Or we know it's like it's coming out of this. And so, we might be just getting them from everywhere. Anything that gets filtered into the urine will get picked up. We can't really say that they're definitely from there.
Yeah.
Yeah.
Although clearly the progress with posterior urethral valve proteins certainly outstrips that of unilateral hydronephrosis. no question about, but it just seems to be such a shotgun approach to it, you know.
Yeah.
I'm not being critical, I'm just being analytical
Yeah.
in terms of the way one approaches this, you know.
Right, right. And that's sort of the way genetics is going. I mean, you're doing the, genome-wide assays, and you're not trying to pick out something specifically. You're just trying to see what pops up when you look at
Yeah,
these thousands
yeah,
upon thousand, and it just makes it harder for us to interpret. It's like when I get a
yeah,
genetic report, I mean, I have to ask the geneticist, what does this mean? Because, my brain can't get around all these numbers.
yeah. I get that. I get
Yeah,
it.
yeah.
Thank you both. Is somebody have any question? Let me ask you something, Xiang.
Mhm.
Is there any use or limitation during the inflammation process, the use of these proteins?
Okay. The Are you asking, are there inflammatory markers that would be useful in
The,
assaying?
the use of this one in inflammatory processes.
Yeah, yeah. There have been one or two papers that have looked at that um, as markers of um, posterior urethral valves, and they're inflammatory markers. And the comment that we got back on that is that those markers are excreted at much lower levels, like maybe 1,000-fold lower than the protein levels that are for posterior urethral valves. So it can be done. The problem is once you're again dealing with the very, very low concentration of these markers, it becomes fairly inaccurate, okay, because you're looking at very small levels, and then you have to decide what cutoff is important. So yes, it can be done, but technically it's even harder to do because you're dealing with specimens that are like 1,000-fold lower in what you get out.
Any questions, somebody? Tony, do you want to comment something else?
Not much to add, except that I do think we need to continue research in this area, because I think what the best we can do right now is following tests that in some cases are quite invasive, um, have variabilities associated with how they're done, have subjectivity in terms of how they're interpreted, and as I mentioned before, may be seeing an effect that we can't reverse, but only stabilize. So pushing this forward as far as we can in order to be able to develop biomarkers which have all of the idealistic characteristics that Young talked about, I think is an area that we need to continue to support and promote. Chairman, I think you're muted.
Sorry, I've been telling to you to see any recommendation that you can give to the people that have no access to this methodology.
No, I don't have I don't have a great way of doing that. They did point out that there are, I mean, even within the EU, there are times when the assays don't work well. And it has to do with contamination of the specimens, between the time that they're obtained at the local hospital and the time that they arrive, at the study center. So my guess would be if you really want to do this, you could, contact the people that are doing the study and see how exactly they would want it. But I assume it would be the issue of shipping that specimen over to the EU lab, and then funding the costs of the assay, either individually, or unless the National Health Service, wherever you're working with, would be willing to pay for it. And so, yeah, the problem again is like you need all that expertise in one spot. It's very hard to move it across different centers. So it would be like almost like trying to get a patient into a multi-center trial when you're not originally in the trial, and to see how that would work. Yeah, because we don't have that here. Yeah, in the U.S. either. Yeah.
People, any question? No? Okay, I will say thank you to Siyang and to Anthony. Thank you very much to be with us as always. And the next time, maybe you can be with us, okay, here in Bolivia. I
Great.
hope.
Yeah. Thank you.
The next talk we have again Dr. Anthony Calamone and Dr. Brad. They will talk about Wilm's tumor. Okay, the next talk, the next month. Okay, thank you very much to everybody to be with us. Tony.
Thank you. Thanks for organizing things, German. Appreciate the ability to participate.
I'm sorry for my English. Sometimes it's not good.
It's a lot better than our Spanish. Don't worry.
Thank you.
Nice to see you again, Tony.
Thanks.
See you.
Here.
Thank you very much,
Take care, everyone.
everybody. Thank you for
Bye-bye.
being with
Great
us
job. Great job,
again.
Young. Well done. Take
Okay,
care.
thank you, everybody.
Bye-bye.
Bye-bye.